diagnostic tests. I would like to invite our next speaker, Dr.Maria Priyanka. Priyanka is presently working as a consultant in cornea and refractive services at Agarwal Eye Hospital, Vellore. She has completed her MS Ophthalm from CMC Vellore and finished her cornea fellowship at Shankar Netralaya, Chennai. Over to you, Dr. Priyanka.
Good morning, everyone. I'll be talking about the treatment modalities, choosing the apt tear substitute and newer treatment options. Excuse me. So dry eye disease is the most common encountered condition uh, which we see in our OPD, where a lot of overlapping symptoms their patients usually come with. So here is a plethora of symptoms they usually present, but stepwise approach to manage them is very important. We have to diagnose the cause of DD. Knowing the severity of the condition helps us to come to a conclusion on the apt tear substitutes we are supposed to use. So artificial tear substitutes are the first line and mainstay of treatment. The natural tear film is highly complex multidimensional fluid gel solution that ensures normal homeostasis of the ocular surface. Therefore, any artificial tear substitutes which we are using should be aimed at treating the condition and replacing the normal tears. But which one to use? So understanding the components help us to choose that, so that a particular dry eye disease can be targeted and for the best of the patient's comfort. So Barabino et al. Has categorized the tear substitutes into wetting or lubricant agents, which bring about the tear film stability, which includes oiling agents and the viscosity enhancing agents. Then the multiple action tear substitutes improve the quality and quantity of the tear film, and ocular surface modulators interact with the ocular surface and thereby heal the epithelium of the ocular surface, which includes the osmoprotectants and agents which promote the wound healing. So as per the dry eye definition, the words highlighted show the pathology we are supposed to treat here. The first one is the tear film stability can be treated by giving an active ingredient or a viscosity enhancing agents. Loss of homeostasis, hyperosmolarity, and ocular surface inflammation can be controlled by using a biological active excipients. And the third component, which is important in any drop, is the preservative. So in the active ingredients, the main action of them is to wet the ocular surface, retain water, enhance the viscosity, and reduce the irritation. These all bring about a stability in the tear film. These are a list of FDA approved active ingredients. Up to maximum of 3 can be combined in any ATS. For any ATS which is coming into the market, has to be from one of them. And these include the most commonly the CMC, HPMC, PGPEGs, polymers, which are seen in almost in every drop. Then the next is the biologically active excipients. The main action of them is to protect the promote epithelial growth, anti-inflammatory, and regulate the osmolarity. These include the osmoprotectants, which mainly take care of the epithelium, reduce the apoptosis, improve the healing of the ocular surface. Humectants, which are now in the market, seen in most of the drops, are hyaluronic acid and HPQR. They not only take care of the epithelium, but also improve the viscosity. Therefore, in some areas, these can be categorized as an active ingredient also. The others are oily agents, surfactants, electrolytes, antioxidants to stabilize the tear film, and agents which promote wound healing. So the last component is the preservative. We know that the preservatives are to reduce the microbial contamination, but we also know that the older preservatives such as BAC, PHMB, EDTA are very toxic to the ocular surface. Therefore, the newer transient preservatives, also called as disappearing preservatives, have come into existence, where when they come in contact with the ocular surface enzyme or the environment, decompose into harmless water, oxygen and carbon dioxide. So even the SOFSIA ionic buffer system, which was recently introduced, also follows a transient preservative rule. Still, if we want preservative free, we can go for unit dose containers or a multi-dose containers which has a complex cap design which allows the fluid to flow only in one direction, preventing the egress of the organisms. So the use of ATS should be tailor based. One size fits all would be an oversimplification. So the broad principles of ATS use should be: treat the patient's symptoms, avoid symptom escalation, dilute and remove the ocular agents and inflammatory products on the ocular surface. This is achieved by adopting the following strategies to streamline the approach. So choosing the ATS based on the ingredient. In aqueous tear deficiency, the viscosity enhancing agents are used. Humectants or oil emulsions in the evaporative dry eye. Osmoprotectants when there is hyperosmolarity. Osmoprotectants and hygroscopic agents when there is an epithelial damage. The second step is choosing the ATS based on the severity. Milder cases go for lower viscous agents. More severe, increase the viscosity. Frequency of instillation should depend upon the patient's symptoms. When it goes beyond 4 to 6, it's better to switch to the ATS which have these disappearing preservatives or the preservative-free things. Stepladder approach: for milder cases, start with one agent, and if required, other agents can be added. Whereas in more severe cases, start with the maximum therapy so that you control the symptoms immediately and treat the ocular surface. And then it can be stepped down based on how the patient is and once the ideal point is reached. Role of polypharmacy: we know that a lot of ingredients are there. By mixing and matching on them, we can get about the best result and give the best comfort to the patient. Follow-up of all is very important in all the patients, because if any ATS is not working, we can switch to the second line or add on a drug again for the patient comfort. So whether it is an aqueous tear deficiency or an evaporative dry eye, first diagnose the severity. Use in lesser cases, for example, in aqueous deficiency, use less viscous agents in the early stages. As the severity increases, use the higher viscous agents. And if any epitheliopathy is there or we need to add on, then a biological active ingredient is added. Similarly, in evaporative dry eye, using of the active agent and a second line when there is an epitheliopathy, you can add on the biological active ingredients which are osmoprotectants and hygroscopic agents. So few practical tips are: it may not be relevant to be using artificial tear substitutes in bedtime for evaporative dry eye. Using gel ointments at bedtime will be beneficial. Titrate the frequency depending upon the patient's symptoms. Avoid high viscous agents in working individuals. Be aware of all the components, not just the active ingredient. When there is a epitheliopathy, add on a biologically active ingredient and avoid unwanted polypharmacy. So if still after giving all these, if the patients are still not able to be symptom free, then alternative strategies like tear preservation, which include punctal occlusion, tear stimulation with multiple drugs, can be done. Control the inflammation with steroids and immunomodulators. Treat the concurrent lid margin disease. Control the underlying systemic condition, and in severe cases, use of Pros lens, autoserum tears and no growth factors will be helpful. So the newer treatment options, we'll discuss this in 3 categories. First one is to stabilize the tear film. Second is to control the inflammation and heal the ocular surface. There are certain ways where we can treat the blepharitis and to treat the MGD. So the list is extensive, but I'll be discussing few, and those which are FDA approved. Tiruvaya and intranasal nerve stimulator they stimulate the nerves in the nose and help in increasing the tear production. Cequa and Vivi are higher concentrations of cyclosporin, which are in market now, which are used to treat the inflammation. Xiidra is a lifitegrast drug which downregulates the T cell activation and controls the inflammation. Also, we know that serum eye drops are being used now, which contains eye platelet-rich plasma and plasma-rich in growth factors, again to treat the ocular surface pathology and control the inflammation. And there are some treatment options available to treat the blepharitis. Blefex is a medical grade sponge which is held on a handpiece, and it spins around at the base of the lashes to clean the eyelashes ends. Zemvi is a solution which paralyzes the demodex which is on the eyelash and effectively killing the organism. And to treat the meibomian gland dysfunction, we know that a lot of them are there in the market, like LipiFlow, IPL, Tear Care, Meibothermoflow. All these essentially give heat to the meibomian glands, liquefy the meibum, and that is extracted from the glands. Meibo is another drug containing perfluorohexooctane, which increases the lipid layer of the tear film and controlling the evaporation. So I conclude by saying that when considering the efficacy of tear supplements, all of them treat the patient's symptoms, some treat the pathology, but none treat the etiology. Dry eye is here to stay. Tear supplements are currently the mainstay in the management of DED, offering the therapeutic benefits. No one class is beneficial or superior to the other. Therefore, having protocols to initiate treatment in mild, moderate, and severe cases should be in place. Thank you.
Thank you, Dr. Priyanka. That was quite an extensive overview of the various treatment modalities. I think we can just, before going to the next talk, we can probably take one or two questions from the audience. If anybody has any questions.
Ma'am, it was a very extensive talk and good talk. And this demodex killing, is it, she told about a paralyzing and killing the demodex. Is it into market and?
It's FDA approved, but I don't think it's available in India.
Okay, thank you.
How long can you give cycloamine?
How long? So, all these cyclosporin or any immunomodulator do take a time to start the action itself, which is usually 4 to 6 weeks. But they say the newer one, Sequa, the onset of action is even quicker because it has some nanomicellar technology. The initial inflammation has to be controlled because once the action starts, it takes at least, it's better to give for 3 to 6 months. And then once the eye is quiet, the inflammation is okay because MGD, once it is treated, continuing the lifestyle modification, treating the regular massages or whatever we advise the patient should be in place. Again, if that is not, then again we reach to the starting point. So that if those things are reinforced, after a certain time, I think we can stop the using of cyclosporin.
To your question regarding Demodex, actually I don't think lotilaner is available, but still the current management in our practical setup would be using tea tree oils. Tea tree oils in its concentrated form, not the shampoos which we get. It may not be the correct concentration. And also you can use ivermectin creams. They are actually skin creams. You have to apply it in and around the near the eyelashes and little above and below also, to take actually it is set from the lashes to the eyebrows, this area, so that during the migration of the mites along the skin, and they can get killed. And it is said to be taken for 6 weeks to take care of the entire life cycle of the organism. I don't have any experience.
Not yet. No, when they brought it out, it was quite expensive. It used to be somewhere 25,000 for 1 month's dose. Okay, now they have come down to 2,500. That's it. That's yeah, because of various other reasons. I agree. Yeah, they've recently reduced it to 2,500 for 1 month dosing. And regarding the duration of cyclosporin, there is no definite guidelines, and there is published data to say that up to 4 to 5 years of topical cyclosporin doesn't cause any problems. So yeah, it is based on case to case.
They're also supposed to contain less concentration of probably you can use it as a maintenance therapy. The ivermectin cream is very useful. It's a skin cream. Try to avoid it going inside the eye. Within 1 week, it actually clears the entire demodex. But you are supposed to continue it for 6 weeks, following which you can.
Is it available? Yes.
Lid margins and little below, over to the skin. And after that, probably you can it may come back. So at that time you can maintain it with lid wipes or the shampoos.
Even oral ivermectin has been prescribed for demodex.
Single